All right, party people. Today we're going to be covering Streptococci. So, Strep pyogenes is group A strep, Strep agalactiae is group B strep. These are both beta hemolytic. This means they cause complete hemolysis on blood agar. This appears as a clear zone around the bacteria. Do not mistake A and B, meaning alpha and beta hemolysis. That's wrong. They are both beta hemolytic. Alpha hemolytic means an incomplete hemolysis causing a green zone on blood agar. Gamma hemolytic means that there is no lysis on blood agar. Now, strep pyogenes is bacitracin sensitive. Strep agalactiae is bacitracin resistant. Strep pyogenes is a gram-positive cocci in chains, unlike Staph aureus, which is gram-positive cocci in clusters. Enterococci and viridans strep are also gram-positive cocci in chains. For cellulitis and bullous/non-bullous impetigo, Staph aureus is more common. For erysipelas, group A strep is more common. Strep pyogenes causes strep pharyngitis. That's a sore throat. This can lead to scarlet fever. Scarlet fever presents with a strawberry tongue, diffuse salmon pink rash, and you treat this with penicillin to prevent rheumatic fever. Rheumatic fever is a type 2 hypersensitivity reaction. The way that this works is that the immune system forms antibodies against the M protein of strep pyogenes. This is due to molecular mimicry. These antibodies cross-react with mitral valve antigens, which look like the M protein of strep pyogenes, initially causing mitral regurg, and over time, and due to scarring, causes mitral stenosis. Next up, let's get familiar with the mnemonic Jones for rheumatic fever. The J is for joints, arthralgias. O is for heart, the myocarditis, pancarditis, and mitral involvement. N is for subcutaneous nodules. E is for erythema marginatum. The S is for Sydenham chorea. This is abnormal movements from CNS autoantibodies. Next up, we have post-streptococcal glomerulonephritis. This is a type 3 hypersensitivity reaction due to immune complexes depositing in the subepithelium of the kidney. Do not mess this up with IgA nephropathy. If you have a patient with a sore throat and red urine 1 to 2 weeks later, that's post-strep glomerulonephritis. If you have a patient with a sore throat, red urine 1 to 2 days later, that's IgA nephropathy. IgA nephropathy often follows viral upper respiratory tract infections or GI infections. This is associated with Henoch-Schönlein purpura. For post-strep glomerulonephritis, this can follow skin infections too. For example, if you have a patient with yellow crusty impetigo, followed by red urine a week later, that's post-strep glomerulonephritis. Rheumatic fever, however, only follows pharyngitis or scarlet fever, not skin infections. Staph aureus is associated with toxic shock syndrome. This is from tampons or nasal packing. Strep pyogenes can cause toxic shock-like syndrome due to exotoxins A, B, and C. If a patient has cellulitis and shock, and blood cultures show gram-positive cocci in chains, think strep pyogenes, not staph. Next up, we have to run through the central criteria for bacterial pharyngitis, and basically they used to differentiate between bacterial versus viral pharyngitis. Now the criteria is fever, tonsillar exudates, tender anterior cervical lymphadenopathy, and the absence of a cough. The absence, not a cough. The lack of a cough is a point. So if you have 0 to 1 in terms of the central criteria, this is likely viral, and the treatment is supportive care only. For example, you would give a warm saline or lidocaine gargle, or if it's 2 or above, then you do a rapid strep test. If that's negative, you follow up with throat culture. You then treat with penicillin or amoxicillin. Now, if you treat the patient and then a rash develops, in young children, suspect penicillin allergy. If it's a teen or adult and they have a rash, after you treat them, think EBV, Epstein-Barr virus, because this causes a rash when treated with amoxicillin. EBV can present with all 4 central criteria, and this mimics bacterial pharyngitis. Next up, we're going to get into pandas, and I'm not talking about the bear. This is pediatric, autoimmune, neuropsychiatric disorders associated with streptococcus. This presents as motor tics, OCD, or ADHD following strep throat, and it's associated due to elevated anti-streptolysin O titers. All right, moving on to group B strep, that's strep agalactiae. This is a major cause of neonatal sepsis, pneumonia, and meningitis. If you have a neonate, sepsis, pneumonia, and meningitis, and it shows gram-positive cocci, then you think group B strep. If it shows gram-positive rods, then you think listeria. And finally, if it's gram-negative rods, then you think E. coli. So gram-positive cocci, that's group B strep. Gram-positive rods, that's listeria. Gram-negative rods, that's E. coli. For group B strep screening during pregnancy, this is done with rectovaginal swab at 36 weeks. If it's positive, you give ampicillin or penicillin within 4 hours of delivery. And you do not, I repeat, you do not give prophylaxis based on previous colonization alone. Indications for empiric prophylaxis without current test results is if the mother has a fever of over 38 degrees Celsius, if the preterm labor ensues under 37 weeks, or if the mother had ruptured membranes that have exceeded 18 hours. In terms of alpha hemolytic streptococci, strep pneumo and strep viridans fit in this category. This shows a green zone on blood agar. Strep pneumo is a gram-positive diplococci. Don't confuse this with Neisseria, which is gram-negative diplococci. Strep pneumo is the most common cause of lobar pneumonia, otitis media, meningitis, and sepsis in sickle cell or asplenic patients. Now, in terms of lobar pneumonia, please know that right lower lobe consolidation is most common. You'll also find dullness to percussion, as well as a high fever. I'm talking about over and around 102 Fahrenheit. That makes this likely strep pneumo. As far as atypical pneumonia, what you'll find is bilateral interstitial infiltrates, a lower fever, and this will be found in young adults. That makes this likely mycoplasma pneumonia. Mycoplasma pneumonia causes cold agglutinins. This is IgM-mediated hemolytic anemia and a positive Coombs test. An important distinction. So if you have a patient with pneumonia and interstitial markings are present, even with only lobar consolidation, the answer is still mycoplasma pneumonia. Just because you see lobar consolidation doesn't mean it has to be strep pneumo, but it does mean that if you see interstitial markings, you are going to pick mycoplasma. So for asplenia in encapsulated organism, the spleen normally clears encapsulated bacteria. This is via opsonization and phagocytosis via IgG and C3b. Without a spleen, you're most susceptible to strep pneumo, Neisseria meningitidis, and H. influenza type B. These all require vaccination in asplenic patients. Now the schedule for strep pneumo vaccine is given at 2, 4, 6 months of age, as well as to adults 65 years or older. It's also given in high-risk groups such as those who are asplenic, those who have cochlear implants, or those who are immunocompromised. As far as strep viridans, this is aka S. mutans, aka S. sanguinis. This causes subacute endocarditis. This is associated with dental procedures and mitral valve prolapse. Moving on to gamma hemolytic streptococci. Here we're going to be going over enterococci as compared to strep bovis. Both are gamma hemolytic, meaning that there's absolutely no hemolysis. Enterococci can grow on 6.5% sodium chloride, where strep bovis cannot. Enterococci rarely cause endocarditis after GU procedures, such as TURP or catheters. Enterococci are gram-positive cocci in chains. You can treat enterococci with ampicillin, and if it's resistant, you move on to vancomycin. And as far as strep bovis, this can cause endocarditis associated with colon cancer. I'm just adding this because they sometimes do test it. All right, that's it for this one. Go crush it.